done elsewhere. But looking at the past, what have we done? Looking at the present to be able to forge a focus for what we should do in the future. Now, a bit about GS1. I know my VP has spoken about us, but just to highlight a little bit more, we are in over 112 countries across the globe. We are a non-profit organization, so we always stand neutral between partners as discussions are being done. Ours is to enable and engage, that's what we do, and provide a pathway for discussion. But like she has mentioned, the barcode that you see on the water bottles in front of you, as of today, that standard does over 5 billion transactions a day worldwide. That is how entrenched we are across the globe. Our standards are used globally, all over the world. The most important thing about our standards is that they are user-driven. They come from the needs of users across the globe. They are developed by people who find challenges and are willing to solve them. So it's not a product of legislation. It's not a product of compulsory usage. It's a product of something I like to call common sense. The barcode, which was developed over 40 years ago, has also been very vital as the foundation of most of the standards that we use across the globe. And one of the things we are proud of is it has been named as one of the 50 most important things that have happened to the world. We continue to innovate. We continue to make changes in different sectors of industry. We are in every sector you can think about. You'll find us in retail, you'll find us in apparel, transportation, logistics, defense, name it, our barcode is in there. And of course, today, the centerpiece of what we're talking about, healthcare. Now, in Africa, we've been working with healthcare, and we've had our challenges, some of which we all know. Inadequate funding, it's part of it. We've not had a common focus to try and tackle the challenges before us. And Africa happens to be one of the fastest growing population across the globe. Like the minister said, Ethiopia has a young population. You can say the same thing about Nigeria. 70% of our population are also youth. So you will find this repeated across Africa. When you have a young population, that means you have a long, there's a need to have a good healthcare infrastructure to support them, because there cannot be any form of development without healthy people around. So some of the challenges we have, they are not new, they are not insurmountable, but there are things that when we look at, we will be able to solve while working together. You look at another one, we have poor pipeline monitoring. What do I mean by this? It's a supply chain. Like any other industry, the healthcare relies on a supply chain. But unlike any other industry, the supply chain of healthcare must be well monitored. Because healthcare influences that. At the end of the day, if I sell you a bad soap, maybe you don't get clean. But if I sell you a bad medication, you can die. And healthcare is that important. It's the only industry that directly affects life or death. So there's a need for us to clean up that pipeline and to reorganize the supply chain. Warehouse and distribution is a strong part of this supply chain. From the manufacturer to the distribution system, you have things in the healthcare sector that needs to go through a cold chain supply chain system. You have last mile issues. You have stocking problems. These are challenges that I know some of our donor partners are very, very familiar with as they work in Africa. These are issues that we need to face. Visibility is another very big issue. Imagine someone who spends a lot of money bringing malaria tablets or vaccines into your country, and then you end up with a batch that has expired before you. It's a waste that should not occur. These are things that are happening. The present status that we have, visibility of commodity is a problem. Accessibility is a problem. These are things that we need to look into. Inadequate healthcare delivery system. These are things that are currently in front of us that we need to tackle. We need to look at the fact that our healthcare system in Africa don't talk to one another. The pharmacist, the retailer, the hospital, they are all working in their individual silos, but they all provide me with a common service. So when I go to an hospital, why is it that the pharmacy that is selling me the tablet does not know where it is coming from or not guarantee the source of that medication? These businesses don't run individually. We need to find a way of creating interoperability amongst them. Wastage is another thing, not only of your production, but of the time it takes for you to distribute, of the time it takes for you to get feedback, and for you to be able to stand solidly behind your product. These are things that we need to do. Creating visibility is a must. Some of the challenges that we have in the healthcare industry can be summarized in a quote that I found from James. Malaria causes 69% of deaths. Though we can deliver short-term aid and through to develop innovative vaccines or treatments for the diseases, the real issue is the danger of a weak healthcare system. The real issue is the danger of a weak healthcare system. That truly is the danger. And that is what we need to fight. As manufacturers, stakeholders within the healthcare supply chain, whatever it is we do, doctor or pharmacist, we ask for the best. And I think it's good that we have the young population. That means there is hope. 30% of the market in parts of Asia, Africa, Latin America, we all have this counterfeit problem. And the numbers are starting. These are things that we know we can fix. So what is the future? The Africa that we know. What do we want to see? We want to see integrated data capture. These are things that I know a lot of people will talk about: traceability, track and trace, visibility. All this does not happen overnight. These are things that you need to build systematically by creating the necessary foundation. And that foundation starts with picking the right standards that connect you with your trading partners across the world. Because Africa as a continent does not stand on its own, it's a part of this world. And we will trade across nations, amongst ourselves, also with countries outside Africa. Data capture, visibility, anti-counterfeiting, end-to-end visibility. These are some of the things we all want to see happen in the future of Africa. I want to be able to say categorically that when I take that malaria tablet, I am taking an authentic malaria tablet. I want to be able to say when USA distributes nets for malaria prevention, that they don't go to waste because they can't get to the IDP camp. There are several challenges that are out there, but working together, we can definitely create a synergy and a working standard that works. The healthcare system that we put together creates a communication and enabling environment that goes from the manufacturer to the distributor, to the pharmacist, to the retail, and hence even at the patient's bed. Not only will you be able to save life right there when you are giving medications to the patient, but you will also have visibility across the whole supply chain. At the base of this is our barcode standard. Those unique identifiers that you are also familiar with when you go check out groceries. They are the same thing that you have brought on board using our data matrix to put together all these identifications to make sure that we then create visibility to the movement of this product. The benefits of traceability cannot be overemphasized, and I know that throughout the course of this program, you will keep hearing about traceability. Traceability might be the end goal, but I would also like to bring our focus back to the beginning. I will keep repeating this. The important thing is for us to collaborate together and start at the very beginning, which is the creation of unique identifiers within those each and every product that we need to create visibility of. Now, what we are doing in Africa, as you would have heard, is not new. And it is always good when you are not the first one out of the gate. So a lot of mistakes have been made, a lot of learnings have already been done. And what we are doing right now is take those learnings and bring it to bear here. We have countries who have already taken the lead in doing that, in taking that initiative. And I must commend personally, I must commend Ethiopia for actually taking the lead in Africa. For, to the best of my knowledge, being the first African country in the sub-Saharan nation to embrace GS1 standard and to also look for traceability. Hats off to you. Well, what is the most common thing we see? We cannot predict the future. We have the responsibility to shape it. And in our hands today is the tools by which we can actually shape the future of healthcare delivery in Africa. So, we hold it, we owe it to the future generation to be able to deliver an Africa that will have a progressive healthcare system, taking into consideration all the benefits that we have seen across the globe, bringing it together and shaping it to our own local needs. Because I know in every African country there is those local granular needs. But taking a global approach will only bring you to the finish line enough quick. Because if you develop something that is national and you trade globally, you have not solved any problem. Solve a local problem. What do you do with the medications that are imported into your country? What do you do with the medications that are produced in your country that will be shipped out of your country? So it just doesn't work. The global approach is the solution to everything that we need. The first steps are simple. We need to create a local organization within us. We need to bring stakeholders together. We need to bring the people that require this solution into the round table. And we begin to look at that local problem, but with a focus on the fact that When you solve this local problem, you are solving the global problem. So, I leave you with only one thing. Together, let's build a new future for Africa. Let's change the narrative, let's change the story, and perhaps one day we will be able to lead the world by showing what we have done different in Africa. Thank you.
Thank you very much, Tunde. And I would like to point out that the Duke from Hakka has just done what you recommended as first steps. They brought all the stakeholders together in a group which is now moving the agenda and the roadmap for implementation forward in Ethiopia. That is really, I think, a model to follow. We need to bring all the stakeholders together to drive successfully. With that, I let all of you go into a well-deserved coffee break. And I think if we can be back in 45 minutes, that gives you time to visit also the exhibitors outside, have a look at what they have to show and to say. And we will ring the bell to bring you back into the room. Thank you very much.
depan, lagi depan. Face one, two, one, 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 one. Sekarang dulu first. Face one, two, one. Sekarang dulu first. Face, face one, two, one, one. Sekarang dulu first. Laksanakan bisa ada je. Face one, two. Ano? Face one, two, one. Face one, two, one, one, two. Face. Laksanakan bisa. Ah. Face one, two, one, one. Face.
so much for being punctual and back on time. So we get to the second part of the January session today. And it's a big pleasure for us that we have WHO event here. And we have two people from WHO who will get up to the stage. The first one is my deed, who is the group lead and is working on the issue of falsified medical products and a very long time since yesterday that time. But there's also the other part, and Lisa Hedman from WHO will talk about more the supply chain and procurement management under WHO. Because when we talk about traceability, I think what comes out this morning when we talk on the one hand side about traceability to reduce counterfeiting and address that issue, but at the same time gaining supply chain efficiency and making supply chain more efficient. So with that, Mike, thank you very much, and Lisa for joining us here in Ethiopia.
Wonderful delegates, distinguished guests, ladies and gentlemen. Thank you for that introduction. Thank you to the government of Ethiopia, for Influence Retail, for Open Africa support, and to the organisers of that show to participate in this conference. As you've heard, one of the leads and responsible for substandard and falsified medicines at the WHO. We hear lots of terminology. The first thing I want to do is draw your attention to these two reports. They were launched at the end of November last year by the German Federal, and they're the first documents that have been released from the WHO in 10 years in relation to this topic of substandard and falsified products. The dark blue one is a socio-economic study. There is an inherent concern prevalence of substandard and falsified products in the top 19 general. Work at the global surveillance So these documents were launched because the stimulate everybody and focus on getting attention and the issue of person. We wanted advocacy documents that were going to assist us. So to look at a socio-economic study, the first thing we did was we really published surveys and showed us how certain reports of medicine over the last 10 years. An expert committee of health economists and they established the scope and criteria and hardening criteria. And this ended up with about 100 surveys. And those 100 surveys involved 48,000 samples of medicines from Ethiopia countries. Most of the surveys that were carried out, most of the work was being carried out testing in low and middle income countries. There were a few surveys in high income countries. So the outcome of this work relates to low and middle income countries. And then we looked at the size of the pharmaceutical market in low and middle income countries and started to apply the numbers that were available in the assessment of this data. And you've heard some of those numbers mentioned this morning already. We observed a coverage of medicines that were tested in those 48 countries with maintained. this is an average failure. And somewhere now I think are doing a lot better in my business. And unfortunately, the study, the socioeconomic study also includes three models, one from Edinburgh University, one from the London School of Medicine. The first relates to antibiotics used by children with virus, and the estimate here is, you can see on the screen, between 73 and 1,000. And the second relates to malaria products and the reason, as again was that antibiotics and malaria are by far the most common important medicines that are also so these figures are seen those limitations are studies that have been carried out in studies that are carried out using sampling methodologies, and then there are different testing methodologies. All of these things those guidance as to how you can use it, and those standards, together with the agreed definition of sustained benefits of medicine, which in most cases are very unlike studies that last year and now estimated to include future research, future work, future studies will be taken so that we can get an outcome for it. But of course, just knowing the rate of failure substandard medicine, and it's a specification. That's failed. Is that because it's functioning, or is it because of the poor distribution and storage? It's a variety of these things. And sometimes laboratory analysis is not helpful at all. When scientists come together and better methodologies to be able to indicate lines of stress, how long and then start to direct. Falsified medicines that have been intentionally designed to deceive operations or professionals, including the society, but also genuine it's a different approach. You need to differentiate between substandard and falsified. And typically, substandard medicines are called for a regulatory approach. Falsified medicines can be called for a primary approach. Now, let's turn to the second report, first slide, and this is the one that relates to the cases that we've seen in the WHO to launch a surveillance program in 2014. So as I say, 150 countries are now trained on this system and have These focal points can search the WHO database. This is probably something wrong with functional medicine. It says it's nowhere else in the world. Access photograph library, access to medical hospital reports as well. But the countries with limited capacity or something surveillance systems are used. But on the screen you can see the medicines that are actually created. These are the top therapeutic categories of what are WHO. All medicines fall into these categories. All medicines include repeatedly reported drugs. About 1,700 medicines, medical products, including viruses, have been reported to have substandard consequences. And you can see on the screen anti-infectives and anticonceptives as well. So antibiotics, amoxicillin, and antimalarials, artemether as first-line attack or national defense. But these are not expensive medicine, sometimes inexpensive medicine, generic medicines, seen as we see these cases are when they arrive, they're recorded in a database. We will issue the work but the case of relapse is a focal point into areas so we want to understand what the liabilities in the health system, what the weaknesses, what the medicine this. And that information can really drive capacity building and investment. These three things contribute to each of the cases we see. The first one is constrained access to medicine. It is constrained access that can cause a problem. The second is governance and poor governance practices. And the third is good technical capacity. So just to look at those in a bit more detail. With constrained access, we're talking about availability, affordability, and acceptability. If there's issues around that, that can lead to substandard and falsified medicines. So an example would be meningitis C vaccines, price issues with blood works and price shortages of that particular vaccine. We know there's going to be a season meningitis C that's sold to this particular company. And they're going to get an opportunity. So substandard and falsified vaccines are that link between limited access and emergency for government practices, for procurement practices, complexity of costs, lack of transparency, and if it is practice, loss of management, or corruption. And weak technical capacity, poor oversight, lack of resources, limited awareness. Not just poor oversight by regulators, but poor knowledge of risks within the supply chain itself. And what we do This is the approach that's picked up by countries all over the world. Prevention, systems of intelligence, in response, proportional response. So you can see, and countries will tailor it to their own capacity and capability. You will see supply chain integrity and prevention. But of course, it's also control as well. And these overlap. And these are the significant effort goes into prevention, education, awareness, comprehensive legal frameworks in place, multi-stakeholder engagement, and supply chain integrity. Supply chain integrity is something that our member states now have in place. And there are documents on the WHO website where you see, go to the website and visit pages, you'll see reference to a member state mechanism. That's the oversight of the member states one of their prioritized activities that includes taking place. So already there was some reference to some countries that have flood insurance in place already. On the website, you will find data relating to lots of countries that also engage strongly what member states and member state mechanisms to others in the region. I won't go through all of the different elements of this, but it's not going to be solved by healthcare professionals. It's not going to be solved by regulators. It's not going to be solved by industry, but it needs that multi-stakeholder approach. Key messages from me before I hand over to Lisa, who's now hovering, so my time's up. Political will is required. We need to translate on the ground, in the field, that are sustainable and properly financed. We need to ensure that it's well understood that strengthening regulatory capacity and systems is a good, sound investment for lots of reasons to safeguard the manufacture, distribution and supply of medical products. And finally, we need improved reporting systems and greater transparency within and between countries. And that means effective and wide multi-stakeholder engagement. Thank you for your attention.
Thanks very much, Mick. And I'd like to reiterate Mick's thanks to all of those who have organized, invited us, and made this conference possible. I wanted to share some additional information on some lessons learned from other initiatives, places where we can actually borrow from things that went well, maybe some things that didn't go so well, and maybe things that we wish we had known. Is it to the next slide? Has anybody not seen this before? Anybody? You haven't seen it. Somebody help her quickly, bring her some water. So we all know what this is. We've all seen this complicated visual before about the landscape of supply chains. There are not fewer players in this space, there's even more, and that number is going to keep increasing. This landscape is complicated, and while that might not change, improvements to the usability and availability of data from supply chain is very timely and critical. I want to just share a couple of things that are happening that you may know about. The global demand for medicines goes up as population increases, logically. There are estimates that say that the global demand for medicines is likely to increase by more than 30% by 2030. As we move toward the Sustainable Development Goal, which is Development Goal number 3, which is access to medicines,
doing something about managing this demand is going to be critical. One of the things that's happening while that demand is increasing, so is the incidence of shortages of medicines. Shortages in supply chain, we know about those. There's also an increasing number of shortages that are occurring due to insufficiency of manufacturing, and also, as Mick was talking about, problems where medicines have to be pulled out of markets because they're either substandard or they're falsified. As many of you are aware, the World Health Assembly occurs every year, and it will be opening its sessions in the next couple of weeks. In 2016, there was a resolution passed about shortages of medicines and vaccines, and what is it that we can do about that. One of the specific call-outs in that resolution is improving the availability and reliability of supply chain data, both to inform production, but also to paint a picture of where this problem is really coming from. One of the actions that will happen is a notification portal around shortages. Because one of the things that we know is that once a medicine is in shortage, that marketplace that's out there dealing in falsified products, they already know it. And they're already actively trying to fill that space of a shortage with something that's maybe even worse than a shortage. One of the important areas for us is being able to use supply chain data to inform solutions to those types of problems, both in terms of what demand actually looks like, what we're actually consuming, and what we should be consuming. I want to touch into another area, which is some of the activity that we're involved in terms of health supply data overall. As we all know, digital health is a very large space. What you're seeing here is a vision of what's called the Health Data Collaborative, or the HDC. This is a cooperative. Unfortunately, it's not a funded initiative. It's a collaboration of actors who work in health supply or health data. And so as you can see, health data is a big space. I won't go through every single one of these little bubbles because I think we'll start floating in information if I do that. But one of the things you can see is that there is an LMIS working group. And in that working group is an active discussion of data standards for supply chain. One of the things I want to point out, and I think one of the discussions that's occurring in that group, is that for many, many years, would everybody agree that we've had persistent problems with supply chain data, particularly last mile data for, I'm not young and it's been going on since I've been in this space, and that's more than 20 years. So when we see an opportunity like a data standard or having a global standard that would help facilitate those issues, those persistent issues of both the quality and the reliability of data, they're really key. One of the things that we know is that in this space of digital health and health metrics, one of the things that we do a lot is we base our information on availability, on affordability, and very important elements of around medicines on things like spot checks. So we go to a facility and we say, is one of these 10 medicines there, yes or no? And that's the end of it, and that's the report. And it is a bit of a pity that supply chain data hasn't been robust enough for us to use that instead. So we're hoping that moving towards global standards will actually help improve on that problem and add significantly to these. You see that little tiny bubble off to the side over there. It doesn't have anything to do with how important that is, but what we'd like to see is for that bubble to get a bit bigger. The last thing I just want to, there's two things I want to talk about in addition to this. And I want to bring up something that's happened in other projects, and that's that sometimes we have a complicated landscape of stakeholders and we have a complicated landscape of issues. But something like this affects a number of different areas in our health landscape. One is financing. Anything that we do that changes the way we report, that changes the data we use, it's going to affect financing from our results-based financing. It's going to change maybe how information moves into our insurance mechanisms. It may change how information moves through things like reimbursement models or revolving funds. Another thing not to forget about is when you change the way you talk about something. So we go to a country, we see an essential medicines list. We go to another country, we see a different one. The medicine's kind of the same, and we know that, so that's not really a problem. But when you move into a digital environment, one of the things that's going to happen is that there's going to be a need to harmonize across those definitions. If we're all using a different definition for the same medicine, which is the case in a lot of places, that's actually going to work against us. So we don't want to forget that there's going to be places like the essential medicines list, our procurement lists, our financing mechanisms, that are going to that we can't forget about when we implement this. So going back to that complicated slide and the circuitry of who all the stakeholders are, we have to make sure that we aren't forgetting our policy and our policies, our EML, and some of our practical areas, some of the places where the devil's in the details. And I think you are all more experts in where the devil's in those details lie. But we just like to reinforce that some of these areas, if we tackle them too late, it creates trouble. So tackling them early and often is an important point. One thing I just want to do as a last slide for you is talk a little bit about some of the lessons learned from other initiatives. Some of this comes from rapid reviews that we've done that haven't been published. Others are reviews that have been published. Some is gray information, and I won't go into all the sources, but I just want to flash a couple of things that we've seen. One thing that comes up a lot when you look at literature reviews and that comes up when you read about implementing something like a global data standard. It may have been a different standard. It may have something to do with some of the other areas of digital health that we've done. One of the issues is legislation. And you kind of look at me like, oh, no, not legislation, please. But really, it actually is important because we're going forward, and I see a number of people here who are from funded programs, from governments. We're all dealing in the public sector, but there is a big private sector component. And usually legislation is where those two come together. If it's not required of everybody, then who uses it? So that's an important piece. One of the issues in creating roadmaps and implementation guidelines is really how long does legislation take? It's not an easy process and it tends to take time. So this is one of the areas to tackle sooner rather than later. And I think we've seen some examples of implementation in other countries where that piece has been what we would call a heavy lift. A couple of other places to think about is lessons that we've learned from pooled procurement or other types of collective negotiation schemes. We talk a lot about political will. And when we looked at political will in that context, what we found was that political will had some pretty interesting things behind it. And when you looked at all of the schemes that succeeded, one of the things that they had in common is that they had an enabling environment that occurred long before it was applied to medicines. So we had a number of schemes that actually were born in trade agreements around agriculture. There were a few other ones that were born in agreements around military procurement. And in those spaces, those collectives ended up moving toward medicine later. So it does tell us, and I think we've seen some examples from our other speakers, is that this technology to create data standards has been used in other spaces, and we have an opportunity to borrow from that and borrow well from it. Borrowing from it worked quite well for the pool procurement mechanisms, and it seems like there's some potential for that to work well here. One of the things that I also wanted to bring up in looking at some of these mechanisms that have been in other spaces beyond the data space are that we sort of have this vision of what the benefit is going to be. But we have to stay open-minded because there may be some of the benefits that we don't achieve. But there are benefits that we might not have anticipated that are equally important. So stay open-minded. In the pool procurement and collective negotiation space, one of the things that we know is prices don't always go down. But it does have a stabilizing effect on supply. It has a stabilizing effect that may actually be more important than a price lowering effect. The last point I want to make is that I think, is there anybody here who has not participated in a procurement and supply chain assessment? There was somebody who said no to something earlier and she left, so okay. That means everybody here knows about that. There's a vast amount of assessment work that goes on. And when you read them and when you go look through them and when you look for things like, we have a new way of talking about it, we call them maturity models, or there's other ways of dealing with assessments, but one of the things you look for is digital capacity. And when we look at digital capacity in public health, digital maturity or digital capacity has a life outside of the public health space. And one of the things we have to think a little bit about as we develop road plans, implementation plans, is what does it mean in terms of timing? There's a lot of aspects. I'm certainly not an expert in digital maturity, but one of the things that we know is that I got invited to this meeting, and before I came, two things happened. There were news releases around blockchain, and then there was a second one saying that people were talking about trying to use blockchain in medicine supply chain. So that happened just between the invitation and the trip to the airport. So this is a very, very fast moving space. And so as we make our implementation plans and our investment cases to move this to move forward with data standards, we have to think a little bit about what is the speed at which we have to uptake technology in order to make it realistic, and what does that cost in terms of how long do we actually need to get a benefit out of the investment. So important things to think about in terms of digital maturity is the speed of uptake, life cycle of technologies, and how we actually go forward and use those. So I want to go ahead and give thanks for both Mick and myself for having us here and for allowing us to share some of the issues from our side. Thank you.
Thank you very much, Lisa, and also Mick. Both of them have said that they would take questions. If there are any questions in the room now, you have an opportunity to ask both of them. Mick has also said you can look them up all the time during the breaks. And I would also like to point out that we have a Q&A session on Thursday. And if you have questions for that, which not everybody wants to speak in front of many people. So if you have questions which you would like to pose outside, the first booth to the left is a Q&A booth where you have little stickers where you can write your question on and just stick it there. And we will try to answer that during the session on Thursday. Was there a question?
Yes.
So there was a question. Go ahead.
My name is Hashim Yusuf. I'm from the Anaconda. My question is to Mick. Mick, what do we do to bridge the gap at a point between the endpoint of tracking with technology to the patient, especially with a trial like using Android handheld telephones and so? Because that's a very critical point in the supply chain, and we have been missing it most times.
Thanks for that question, Hashim. There's a number of initiatives going on to try and improve reporting, and part of that diagram I showed you related to improving reporting mechanisms. And products that start to show up through track and trace technologies is one way of doing that. Pharmacovigilance reporting is another way of doing it. We've got 2 trials running at the moment, one in Tanzania and one in Indonesia. And these are smartphone applications for healthcare professionals, where when they suspect there's something wrong with the product, photograph, click 2 buttons, send to the regulator, and there's a 48-hour response. So that sort of technology, those sort of reporting systems are starting to emerge, and they're proving to be good. That particular application, I think there's a speaker will be discussing something around the same application later this week. And we would be interested in rolling that out. Of course, any integration between that and these systems would be useful. But these are difficult things to spot, substandard and falsified products. Substandard usually more difficult to spot than a falsified. It's in the right packaging, something's gone wrong, either during the manufacturing or during its journey. The falsified ones, sometimes through visual identification, you can pick something up. And the other thing to say is we don't usually see an obvious adverse reaction. We have cases with many, sometimes hundreds of fatalities. We've definitely got cases with hundreds of hospitalizations. But in most cases, these products just don't work properly. And suspicion doesn't fall on the medicine. They're hard to detect. So we have to have these reporting mechanisms in place, making it easy for people to report through, and then somebody is going to respond on the end of that. It's no good having the system if you haven't got the response afterwards.
I see no other hand raised, and yes, I can only confirm that there are plans for this kind of systems when you have a barcode and you have a suspect that you just could read that barcode and send a message to the regulatory body and informing them about your suspect. That is one of the future possibilities of being able to identify products, really. Thanks again very much to Lisa and to Mick, and they are around, so don't hesitate to approach them for any questions which you would like to discuss with them. With that, I would like to invite the next speaker to the stage, who is coming from the US FDA. Lee Rabois will talk to us about the approach of US FDA on collaboration for global regulatory strengthening. Thanks very much for traveling to Ethiopia, Lee.
So thanks to the hosts for having us here today, and thanks to everyone in the audience. I'd like to speak to you today about regulatory systems and building out collaboration, and then talk to you a little bit about what the US FDA has been doing with track and trace. So the first part, like I said, is why regulatory system strengthening matters to the US FDA. A little bit of background is why the current state is really so vastly important to the US FDA. And this is not just why it's important to the US FDA, but why it's so really important to everyone in this room. And the reason is that we have around in all of our countries vastly increasing amounts of imports. This is so important to the United States because in the United States we get such a fundamental amount of our pharmaceuticals and medical products from other countries. And so what we need to do in the United States is find ways in which we can make sure those products are safe for consumers. This, when we talk to other countries, is a similar story. And so we work really carefully to make sure that these products are meeting our standards. We do this in a number of different ways. And a lot of those ways involve talking to other countries to make sure that they clearly understand how we regulate products, but also making sure that those countries understand the valuable the value that regulators truly play. So it's not just in us talking to regulators, it's talking to all stakeholders and all of those that have value within supply chains. So that could be academicians, it could be regulators, it could be industry participants. And so we work really hard to make sure that the entire value chain understands the role that they play within supply chains. Another important reason is that we have an extremely limited amount of resources. So we need to make sure that each of our resources are used in an appropriate way. Those resources could be our inspectional resources, the resources we use when we go in to understand what facilities are doing, whether our resources are used at our borders when we're pulling products and making sure that those products are being tested and meet our standards, or our resources when we are sending people out to give presentations. Or and also increase globalization. And what I mean by that is that the products are being made in different areas of the world. What this also is increasingly complex supply chains, and I think everyone in this room understands this fundamentally, and I don't have to get into great depth in this. But one thing I do need to say is that the complexity of products is becoming deeper and deeper. So I think one thing that I do want to say is while we know that products in their whole are being made in different countries, I think that one thing that people are beginning to understand more implicitly is that pieces of products are being made in different countries and are being integrated into products and then being imported into products in other countries and being distributed around the world. And these are being produced and distributed in very complex ways. I think that organizations like the FDA understand this. I think that there we have understood this for a while, but I think that as a whole, the industry and regulators are developing a more fine-tuned understanding of why this is more and more and more important over time. And I think the last bullet is why this is the most important piece, and that is there are complex public health outcomes associated with um, with with all of this, and that is we recognize that there are complex issues such as antimicrobial resistance that result when our products do not meet standards, that when products are not effective and products are not safe, that in the end it's patients who pay the real price. And so we really do want to make sure that everyone is receiving the products that they are intended to receive. However, on the flip side, that when we all work together, when regulators work with regulators, or regulators are working with industry and academia, that we are tightening supply chains, that we are leveraging information from capable partners, and that we are decreasing the global burden of disease, that we all win. And that's why it's really important for people like me and you to work together as closely as we can to decrease the burden on ourselves and make sure that in the end, patients win at this, that we are getting patients the drugs that they need on a regular basis, and that they have products in their hands to treat their families. So that's why I'm here today. It's why I flew for a 14-hour flight to make sure that we're able to have the sidebar meetings that we need to have, and that I, on a regular basis, give presentations like this and have conversations with my regulatory counterparts and build partnerships with academia and have conversations with industry about the value that, that this has. So while this seems like a rather interesting meeting to have this conversation, there's a lot of value that track and trace can play in this entire conversation, that track and trace really can bring a lot of regulatory system strengthening to this. And this is a really interesting conversation for me personally to be having, because when I, about 6 years ago, helped develop an organization within the Food and Drug Administration called the Division of Supply Chain Integrity, where the operational elements of track and trace now sit. So I'm going to walk through a number of rather technical pieces associated with track and trace to help you understand what the US is doing for the development of track and trace standards in the United States. But what I want to do is not just walk through these elements, but tie this into why this is important for the international community. So I'll give the general disclaimer, and this is a disclaimer that we give when we're talking to the community, both from those that might be looking to develop pieces associated with track and trace, and also those looking to utilize track and trace when they are trying to distribute products. So the content here is intended only to provide a summary and general overview. It's not intended to be utilized as a comprehensive or a legal advice. And additional information can be found on our website. So if you are looking to find really in-depth information associated with track and trace, we do provide the most up-to-date information there. And in fact, we will be placing some new information there in either this week or in the next weeks to come. And that is why you don't have a technical expert here on this stage. So in this presentation, I'm going to give you an update on the implementation of drug distribution security requirements for DCSA and provide some recent stakeholder engagement for public meetings and plans for engaging stakeholders. And what you'll see is that one of the pivotal pieces of the US FDA's engagement is actually that stakeholder engagement. And I think what you heard Lisa saying in her previous presentation was that there's a lot to be learned from past experience. So as I was listening to her presentation, I thought, you know, there's a lot of information that I'm going to be presenting that actually might be a little bit duplicative, because what her highlights were, you know, make sure that we're learning from our past experience. And I think what US FDA likes to do is to make sure we're going out for public comment, so that we're not just relying on what we think is the best, but we're going out to the public to make sure we're finding out what's happened in the past, so we're not reliving it, and we're not going to make the same mistakes that have happened, because there has been some implementation in the past for track and trace type systems that have gone out really fast and have stumbled. And so we want to make sure that we're not going to implement something, we're not going to get ahead of ourselves, that we are going to realize that the technology can't keep up with. And then we want to make sure that we're learning from those experiences. And because other countries have been able to get out in it ahead of us, we're able to take that information, integrate it into the programs that we're trying to put out there, and learn from that experience, which is really great for us. So here's a schematic to show that we are looking to maintain integrity from the manufacturer not to the patient. So who touches the product, where vulnerabilities are, and where are the threats. So we're looking to protect the product and protect to the patients. So the goals is to develop an electronic interoperable system by 2023. And what that says to you is that our system, our legislation went into place in 2013. We gave ourselves time from 2013 to 2023. That's 10 years. So an extensive period of time between our legislative authority until the time in which we needed an operable system. What Lisa said was, it takes some time. It takes some time to get your system operable. And, it takes some time to develop some will. And when we were working with our stakeholders to develop some political will for having a system in place, our stakeholders said it's going to take some time for us to get a system in place. And we had to listen to what our stakeholders said. It's going to take us some time to get that system in place. And so as the legislation was written, our legislation took that into account. So that's something that as systems are being developed regionally, it's something that you'd also have to take into account to develop systems. Our system will facilitate exchange of information by trading partners at the individual package level, to improve efficiency of our recalls, enable prompt responses of suspect and illegitimate products, which I'll define a little bit better as we go along, and create transparency and accountability in our supply chain. It'll establish national standards for licensure for wholesale distributors and third-party logistics providers. And as you can imagine, every legislation has definitions in it, and definitions are specific to where that legislation is. So I'll skip over some of that. So we have a path, right? And our path has defined timelines. And it's important as legislation's going through that it defines timelines, because what you don't want is you don't want a 10-year pathway that doesn't help you get to where you need to be. Because if you just have a 10-year plan, a 10-year path, and you butt everything up to the end of the 10 years, it's going to be a really painful point at 10 years, right? So we have defined over a 10-year period how we're going to get to 2023. And right now we're at 2018. So at 2015, we had a specific point where we worked on specific pieces associated with our wholesale distributors and our third-party logistics provider reporting databases, which we've already met our mark on. We held public meetings, which helps us meet our transparency pieces, right? So we go out to our public and say, what do you think we should do with our stakeholders? And so stakeholder engagement is one really, really pivotal piece, as I mentioned at the beginning. How do you think that this will be successful when we're trying to get where we need to be associated with this specific piece of legislation? Because if we don't do it that way, when we go out with the recommendations, we may not actually, one, we may not meet the mark of the legislation, and two, we may just not be successful at all with the plan. So the next step was product tracing. The trading partners need to exchange information. So we had our second public meeting associated with our product tracing information. Okay, and at this we needed to respond to verification requests for suspect information. Okay, so in 2015 we held a second public meeting associated with this, where we went out with a request for public information, where people submitted information associated with what information did we need to capture and how did this information need to come into us, and what elements needed to be part of this. As part of this, we had definitions. As I mentioned before, we had two different things. We needed to capture information because we needed to be able to trace suspect products and illegitimate products. Because someone needed to report whether or not they had a suspect product, and we needed to be able to recall if there were illegitimate products. So at this point, we were able to say that a suspect product, it was a product that we had a reason to believe that the product was potentially counterfeit, diverted, or stolen, subject to fraudulent transaction, or intentionally adulterated or appears otherwise unfit for distribution. And then the second category is an illegitimate product, which had credible evidence that it was a product that was actually one of the above. And as you can imagine, we needed a way to document this. So as part of this process, we have a form that allows one of our stakeholders to notify the agency of one of these illegitimate products in the marketplace, which can be accessed on the FDA website. Okay? And these are in draft guidance right now. So here's a next step, which is the product identification and serialization piece, which is part of the reason we're here today, right? In this section, we need a unique product identification must be placed on certain prescription products in human and readable format. And this needed to happen by manufacturers no later than November of 2017, and by repackagers no later than November of this year. And as you can see, there's specific information that needs to be contained in here. I'm sorry, I'm not able to read this because it's popping in and out of here, so I'm turning my head. So what we have is this information is being is discussed in part of our public meetings. And many of you may have, I know some of you have taken part in these discussions as part of our public meetings. I can see some heads nodding in the audience, and I know I've seen some of you on campus. And this information has been part of drafted guidance documents, which can be found online. So any information that you're looking for is part of this entire package of information that's associated with our legislation. So I recommend anyone who's interested in finding this information, look at the FDA guidance documents online. But it's also part of this transaction that the FDA does in terms of seeking input from our stakeholders to determine what our best path is. And what we do is we get this input from our stakeholders, and then once we receive the input, we actually make edits based on that input, which is a really interesting way in which we ensure that our stakeholders have access to provide their expertise to the FDA, and we are able to integrate that expertise into the path that we take for putting out guidance documents. Without this, we as an agency would be unable to ensure that we're taking that input into account as we're drafting our guidance to industry. So FDA is currently reviewing these comments that we received for this guidance document. So we're in the process currently of developing pilot project programs. And part of our legislation was that we needed to work with industry to develop a number of pilot project programs specifically to track and trace. This was to ensure that we weren't just working in isolation. And we expect to actually have one of these pilot project programs out relatively shortly. We've developed these pilot project programs, like I said, not in isolation. And so we do hope to be able to have integrated within these pilot project programs these types of identifiers and these elements that are listed here. We developed these as part of public workshops to help us really make sure that the pilot projects were as strong as they possibly could be, because we have finite resources. So to put out the pilot programs, we wanted to ensure that they were as strong as they possibly could be, because these will help us ensure that when we finally go to full implementation, we're able to have the strongest track and trace program we possibly can have. The reason I bring this up is that we're not going out with a final track and trace program that hasn't been tested. And that's really important, because without the ability to test what we're able to go out with, and one thing I read is this, has been very, very vocal about the point that we really are looking for an interoperable system, that we're not looking for something that only works for the US FDA, that we recognize that industry's input on the fact that they don't work in isolation is really, really an important piece of the program. And so we've been working really hard to identify that as a critical element of track and trace. And so this is really an important piece of making sure that track and trace is successful in the United States. We've mentioned repeatedly that we've had a number. Here is a list that we've had thus far. The last one was in February of 2018, and I recognize a number of faces from that meeting. Even though I wasn't able to attend it in person, I actually was online watching it from my office while I was intermittently going to other meetings. So here's a recap of those meetings. In the first meeting, we set out to identify what the path was going to be from the first one in August of 2017, which I think is a really important piece to say that you're planning from the beginning, and then laying out that the vision is an interoperable system as early as you possibly can is also really valuable. So this lays out that we are looking for a pathway. It lays out a plan. If you're looking to implement legislation, it's really important to identify that there's a timeline and that there are marked steps to make sure that there's an implementation plan along the way. And we've been trying to strive to meet these deadlines along the way. We don't do this in isolation. We have a number of key stakeholders who watch how we're getting these things done and making sure that we're meeting our timelines. That's good for us. I think that's good for our critical stakeholders who also need to use the system that we're using. But it does make sure that we stay on our toes. So, as I said, we are striving to meet our total 2023 deadlines to establish package level requirements for an interoperable electronic tracing of packages that goes into effect 10 years after the enactment of the Act, and these are the goals. So what's next? As I mentioned, it's the project program We have a number of guidances and regulations. We're trying to do this as transparently as possible because that is generally the goal of the way that FDA does it. We do it through outreach, engagement, and education. And if I were to say the end goal of of the way that we're working, it's through transparency, it's increased security, it's regulatory convergence, it's increased efficiency, and the end goal is public health. So if anyone has any questions, I'd be happy to take them.
Hi, thank you. So, could you give us?
Are you looking for an investment, like a
I'm asking the question because, and this goes sort of in line with the previous presentation around they call data maturity or something like that. But it goes in line with the fact that we're talking about supply chain, and we know that we need information to make proper decisions, right? But then the investment around making that happening is actually very big, and it's normally something that we don't take into account. And as you say, I think your presentation is key on the fact that the timeline to actually make this happen is a 10-year strategic plan. And we normally think in most countries that we can make something happen in 6 months or in 1 year. So the idea of getting like a ballpark number of the investment around making something like this, you know, a reality, and who's paying for that,
Yeah.
if you can.
So I don't have a financial number in time in terms of that, but I can tell you what I gave you in terms of timeline was actually the implementation plan. I didn't include in there the timeline that it took to get the political will. So, you know, in the United States, there was probably a 15-year timeline in advance of the actual day in which we had a law signed in the United States where we were building political will for for the actual signing of the law. So there was probably a 25-year timeline until the 2023 like 2023 date. I would say from an investment point of view, if you wanted to back it up, you'd probably want to build in what Mick has in his report, which is the socioeconomic, you know, investment piece where you have a number of deaths, you have the counterfeit piece, the recalls that you will have to do because you have, you know, products that match your products on a market. There's a lot of ways in which you could actually do the cost associated with products that shouldn't be in a marketplace that are in a marketplace. And so if you're looking for ways in which you make a cost investment, you know, a risk benefit plan piece, I'd be willing to have that conversation, but I don't have that number for you off the top of my head. There are probably people in this room that do, though, if someone would want to raise their hand. Someone raised their hand. I don't know if that's a question or they have the number.
Thank you. Mine is a question. So my name is Patrick. I was wondering on your pathway, so how do you bridge the gap between for example, the dispensers? Because you are collecting the data from where are the 3PLs and the wholesalers. Because I think that's critical for our setting.
So you said, hold on one second, let me go back. You hear from, you're saying the gap here from the 3PLs to, I,
So from the dispensers, that's the like the local pharmacies, then you
yep,
go to the wholesalers, and the local pharmacies interact with the patient. So how is that gap being
from the
bridged? Yeah.
so to the, from the, so our, ours is going to be, it's not on this one, it's on this one, hold on. It's on this one. This is at the pharmacy level where we're going to be doing it.
Thank you.
Hi, thank you for the presentation. I had a quick couple of questions on serialization. So in your path, you show that serialization would be, you're targeting till the end of 2018. So is the expectation that manufacturers who supply to the US market, even from outside the US, will comply by
Yeah.
end of 20?
Yes, they will have to comply.
And do you collect the serial numbers from those manufacturers into a common database, or what's the when you say compliance, are they providing the data to a common repository like how 3PLs and wholesale distributors are reporting?
You know, I don't know exactly because I'm not the SME right now on who takes the data. I can't answer that one specifically.
No problem. Thanks.
Let's see.
Yes. Yes. Hi, Jennifer Ray, PMI. Thanks, Lee, for your presentation. You talked about how this will be done, I guess, with some select products. I'd be interested to know a little bit about the criteria, how you came to that. Was it vendor? Yeah. How did that happen?
So I might have not spoken well about the product selection because it's not product based in that way. It's rather general. Yeah, it's all pharmaceuticals. So if I misspoke on that, I hope to make some clarity. It's pharmaceutical based, so it's across the supply chain for pharmaceuticals. So I'd like to take that. Hopefully that clarified it.
Thank you.
Yeah. Yeah. Then I'd be more than happy to take any questions during the breaks.
If you allow me to make a few comments on the question on the costs. There are costs to traceability. There's no doubt about it. Costs will kept lower if you go with an approach which is global, which means looking at the manufacturers in the room, they have to implement serialization now for countries like the US, like Europe, like Argentina, like Turkey. So if you allow them to do the same also for African countries, this will keep the costs on the manufacturing side lower. There is still the cost for the database and the data collection. There's no doubt about it. But I think we will hear tomorrow from Korea, who has moved forward on that. For me personally, the country who has implemented full traceability for pharmaceutical products is Turkey. Turkey has a central database where they hold all the traceability data from their country. And the Ministry of Health in Turkey has stated that they had an ROI in the first 2 to 3 years of the cost. The benefits have been much larger than the costs, and the outcome they have seen have been incredible and have gone beyond what they expected. They wanted to prevent reimbursement fraud, but they have seen benefits which go much beyond. But we will talk about costs and system this afternoon in the sessions, in both sessions, I assume. I just thought I didn't want to let this just stand in the room. And traceability takes time, but it's worthwhile. I think that's very clear. With that, I would like to invite the last speaker of the morning session, Julia White, who is from the Reproductive Health Supplies Coalition in the US. And she is the Market Development Technical Officer and will talk about some exciting developments you are doing.
So, honorable and distinguished delegates and guests, good afternoon. My name is Julia White, and I am the director of the Global Family Planning, Visibility, and Analytics Network. And it's an honor to be here today with all of you. And I would like to just take this moment to thank the organizers of the first conference here on GS1. I know how big an effort it is to put on a conference like this. So thank you so much for the opportunity today to speak with you all. So I am actually, oh great, it did forward it. So I'm excited today to have the opportunity to take you on a journey. And the journey I'd like to take you on is to unpack the basics of the Global Family Planning, Visibility, and Analytics Network, which I'll call the Global FP-VAN. I'd like to ground it in the history of the Reproductive Health Supplies Coalition, the RHSC, as well as highlight some of the recurring questions and issues that are at the heart of why we're putting in place the Global Family Planning VAN, and highlight also some of the exciting innovations that it looks to put in place to break down the silos and transform the way we are thinking about supply chain visibility. So I'd like to get started with a video. So here goes. The sound is not working.
Stage of that journey, decision makers need data to see where the commodities are. In our business of reaching women with the right family planning commodity at the right time, the right data can make the difference between health and sickness, life and death. These commodities must take long and difficult journeys. At every stage of that journey, decision makers need data to see where the commodities are and to answer key questions. Procurers need to know how many units of each commodity to buy and for whom. Manufacturers ask how much to produce and by when. Shippers must decide which commodities to send where. The central medical store needs to know which commodities to order until finally the commodities reach the world's poorest women and girls. Insufficient or incorrect data at any of these stages will send wrong messages through the supply chain, resulting in stockouts, overstocks, expiration, wastage, and ultimately, empty hands. Since 2004, the Reproductive Health Supplies Coalition and its members have been developing tools and groups to get the right data to answer these important questions. These tools tell us who has purchased commodities, how much, and what country stock levels are. We've brought specialists together to use these tools to help prevent and respond to stock crises. Now imagine if we could get all these tools and groups to break out of their silos and contribute to a single shared virtual platform where the community can see and use the same data to make supply chain decisions together. What you are imagining is a global visibility and analytics network for family planning, or Global VAN. It will link procurers, manufacturers, shippers, and countries in an active network focused on product flow into countries. They will use a new data hub that captures data from many sources and provides a single decision-making platform. New processes will transform how they interact, analyze the data on the hub, and make decisions together. There will be harmonized policies around data sharing and use. The Global Family Planning Van is the natural migration of more than 10 years of work that will allow people to simultaneously see the same data and make decisions together, giving the Family Planning Van to the Coalition. Financial support is coming from committed change leaders, starting with an 18-month pilot. At the center of the pilot will be a focus on countries, a vital component because countries link incoming orders with women. As countries embark on their own data initiatives to strengthen national supply chains, upstream Global VAN and downstream country efforts will build toward one another, with a view to linking up our systems. This eventual link will let us see together where commodities are, all the way down to the last mile. This visibility will help us answer our key questions. This will transform the way decisions are made forever, helping us to reach more women with the right product at the right time. The Global Family Planning Van is the Coalition's biggest undertaking to date and must be a community effort. Join us as we change forever the way our supply chains work, and in doing so, the way we reach her with the family planning she needs.
Great. So what this video really helps to highlight is that our community's questions they remain the same. It's not the questions that have changed, it's the approach to what we're trying to do here. And the Global Family Planning Van is going to bring together people, processes, policy, and technology in new innovative ways to transform the way we answer these questions and make supply chain decisions together. So it starts with breaking down silos and increasing collaboration and how we work together and use the data to reach more women and to do more with less. So whether it's links across key supply chain players, the policies in terms of data sharing, the management questions around how we manage data, or the technology to house and analyze the data, we need to break out of our traditional siloed project mind frames for this Global Family Planning Van to work. So at the heart of it is, as a start, collaboration and partnership across these key supply chain players. So I'd like to start by introducing the governance structure and then the partners who have made a commitment to join us as early adopters on this journey. So for the governance structure, you can see here, we have this visual that shows what we've put in place over the last 6 months. So at the top of the pyramid there is a multi-partner steering committee, which is looking to resolve conflict, to set scope, set direction, and really look at the funding opportunities. In the middle is the management unit, and this is the unit that's really looking at implementation. And then the foundation of this whole pyramid are task forces that we've been putting in place over the last 6 months. So you can see to the far left, the super users, and this is really representatives across the supply chain from procurers, countries, and data analysts who are really going to be looking at the change in terms of the processes of how we do collaborative supply chain management. Then you have the data sharing task force looking at policies, data management that's looking at the structure of the data, and the technology management task force that's looking at the systems themselves. One of the innovations to flag here in terms of the task force is that they've really proven to be a hands-on approach to securing broad-based multi-sectoral inputs into the decision-making process to help make sure everyone has a joint understanding of the vision and the approach, and for giving those involved some skin in the game. So not only are people providing their subject matter expertise, but they're actually being given an opportunity to endorse documents that are going to the steering committee and to have a voice and a seat at the table. And this is really given a sense of ownership at the base of the whole initiative. And now that we understand this governance structure, I'd like to just take a minute to recognize the partners who are active members right now. And so I'm just going to call out to give a sense of all those who are involved. So from the steering committee, DFID, UNFPA, USAID, and a user representative from JSI and RHSC. As well, RHSC is actually the management unit and includes myself as the director and my colleague Sarah Coslin, who is here this week as well. So we'd be happy to answer any of the questions you have. From the super user group, we have we have representatives that I'd start with from the 2 pilot countries. So first, from Malawi, we are working closely with the Ministry of Health and the Health Technical Support Services, with GHSC PSM, USAID, UNFPA, and DFID. And from Nigeria, we're also working with the Ministry of Health with the Director for the Reproductive Health Division and the Family Health Department, UNFPA, USAID, GHSC PSM, and the NSKIP project. From the super user group on the pilot manufacturer side, the 4 pilot manufacturers are Bayer, Merck, Mylan, and Shanghai Dawa. And then other organizations that are in the task force from the technical assistance community include CHI, JSI, GHSE, PSM. So this just gives a sense of the community of partners who are involved with us at this moment. So now that we kind of understand the collaboration that's going on, it's important to understand where we are in the process. And so from the start, we've set up this initiative in distinct phases. So the first phase was really about a collaborative exploratory phase in order to figure out what the community really needed from a technology solution vendor and be clear on our requirements, both from a functional and an IT side. And so you can see on this timeline here from September and October, we were really setting the scope. And then in November, we went into having some workshops to get our process mapping and our validation around our current and future state. And we published an RFP. And then we went through a collaborative requirement refinement process, which I'll talk about more in a minute. The second phase that we're in right now is really the system selection phase. And so we've gone ahead and taken all that collaborative requirement refinement and finalized those into a set of IT and functional requirements that were published in an RFP addendum. We went ahead and did a proposal due date. We did demonstrations and sandboxing with the vendors, scoring, and we are currently now in the negotiation and contracting phase. And so the final stage, which is here at the end of this backward S, is where we're going to sort of launch this field testing to actually go out and make the business case for scale up in a limited scale. So I've mentioned the 2 countries, Malawi and Nigeria, as well as the 4 manufacturers, as well as focusing on 2 product families. So it'll be oral contraceptives and implants. So now that we understand where we are in the process, I wanted to just talk about what we've already done or are planning to do in terms of innovations to actually breaking down some of these silos that I was talking about. So first, just to state the goal of the Global Family Planning Van. So if the goal is to better aggregate, share, and align country demand data with production, procurement, and funding in order to avoid stock imbalances and maximize use of limited resources and to ensure continuous availability, then we have to have linked visibility to the same data at the same time across key supply chain players. So innovation number one is really focused on people. It's that the procurers, the data analysts, the manufacturers, the shippers, the countries, they're all on the same platform designed to increase data visibility between relevant partners for more collaborative decision making. So this data access and process is meant to be multi-directional based on user roles and purpose. So what's the impact of these linkages? So I wanted to look at a couple of examples. So for procurers, what we're looking at is if they want to be able to better align country demand data with actual procurement and funding that's available. Manufacturers, they want to be able to help enable us to identify trends in the community to be able to better align demand with production. And countries, they want better visibility to orders and shipments to help link those to women themselves and proactively respond to stock imbalances. So given the vital role that countries play in all of this, I just wanted to call out that we've made sure to have countries at the table from the beginning of this in the design process, in this very important role to link together this global upstream piece with the downstream piece down to the last mile. So let's move on to the second innovation, which is really around the theme of data sharing. So as you can see in the goals here, you can see highlighted the word share. So really this is important because the Global Family Planning Van is only going to exist if there's data. So if it's that data that's going to allow us to actually see where the products are and to make decisions that will help in terms of product flow and availability. Where possible and appropriate, therefore, the Global Family Planning Van is looking to increase this data visibility by increasing data sharing. So it also only exists, therefore, if the key supply chain players that I mentioned actually are willing to share that data and use that data. It's that data itself that's going to make the difference. So in the goal, you can see that the data must be shared across these supply chain players to make a global family planning van. So in terms of the innovation, a more efficient global family planning van will demand streamlined legal parameters when we think about sharing data and ensuring visibility. Traditionally, the issue of data confidentiality has been dealt with in bilateral agreements between two parties, which when it comes to multilateral groups like what we are talking about can become very legally and logistically cumbersome and confusing to determine how to share that data. So innovation number two is focused on policy, and we're trying to put in place resolving these barriers by looking at multilateral data sharing agreements rather than the more traditional bilateral. And this, of course, will hinge on the robustness of a role-based data security model. And so that's where we're working closely with the manufacturers and countries to get these role bases right, as well as with the upcoming vendor to make sure the security is in place. And as I said on the last innovation, when it comes to this innovation, given the vital role that manufacturers will play, the four pilot manufacturers have had a seat at the table since the beginning in the design, and we're working closely to figure this innovation out. So the third innovation, and the one that is probably most aligned with what we're going to be discussing this week, is in terms of data management. So as we all know, that is that if data is labeled in such different ways that it's no longer possible to be aggregated or to compare, then it becomes useless. Just imagine if we didn't have standard ways to talk about time or distance, then in our daily lives, we'd really struggle to compare to one another what we were working on. So if the global family planning van goal is to be reached, data has to be similarly labeled and mapped for us to use it and consume it. Instead of this initiative creating a structure that only it uses, we wanted to follow a standard structure or common language that the whole community could use so that our data would be able to talk to each other. And so you've guessed it, as that structure, common language, as you would probably guess, it's going to be the GS1 standard, and what is currently used, as we saw, by over 1.5 million companies of every size. So it's that the Global Family Planning Van will follow GS1 standards for product identification, and that we are working with USAID, the GHS CPSM, and UNFPA in this regard. A key objective of the pilot is to prove that the GS1 standard can drive efficiencies in supply chain coordination and address the critical need of having a harmonized and standardized product master. And as supply chain trading partners know, and everyone in this room knows, product and location master data are the basis for business transaction. And so the core in terms of the success of the Global Family Planning Van initiative will be really to be looking at that. And through the implementation of the global standards, the community is excited about the prospect of improving the quality of master data through the implementation of the GS1 Global Data Synchronization Network, or GDSN, for master data exchange over the next several years. In the near term, product and location master data for the Global Family Planning Van pilot will be provided by the GHS CPSM and UNFPA. But in the long term, the vision is that once we're scaled, the Global Family Planning Van will source product master data directly from the GDSN. In terms of the interim, RHSC will partner with GHS CPSM to leverage data sourced from their GDSN data pool subscription for the Global Family Planning Van's product master data file. So the last innovation to talk about is in terms of system selection. So to do all of this aggregating, sharing, and aligning of decision making, we need supportive technology. And we need this to help us to make it easier and better in terms of what we're actually doing. So as we heard in the video, for over a decade, our community has put in place important supply chain visibility tools like the procurement planning and monitoring report, like the reproductive health interchange and others. But their siloed and outdated technology has led to inefficiencies around data cleaning, triangulation, and collaboration. So to this end, the Global Family Planning Van is the national migration of over 10 years of work onto a more advanced, flexible, and virtual collaborative platform that's going to allow teams to simultaneously see these same data at the same time and make decisions together. Innovation number 4 is really focused on technology in the system selection process. And an important first step in this work has been the development of that agreed upon blueprint that I mentioned before in terms of having both functional and IT requirements set up. But unlike a typical tender process where there's only one buyer calling all the shots, the Global Family Planning Van initiative has many buyers because it's a community initiative. So a very collaborative process had to be put in place for us to really define the requirements and start to even think about a procurement process. So first, we established a 3-stage request for used an interactive software called Basecamp to allow for open but secure way to manage access to documentation, conversations, and updates across the community and the bidders alike at the same time. And finally, we integrated use of regular task force meetings, Basecamp, weekly Basecamp calls, and recordings of together on defining those requirements together to make a collective ask of the bidders. So all of this work to form the basis of the RFP addendum that I mentioned when I was showing the timeline, including all the final business and IT requirements, the proposal templates, the scoring guide, and the process for choosing the system. So now we have finalized the scoring and we're in the negotiation and contracting phase, which ultimately should culminate in having one technology solution partner selected. So that's it for what I was going to share in terms of sort of the Global Family Planning Van and the innovations that we're doing and the link with what we're talking about this week. If you'd like more information, I am here this week. My colleague Sarah Coslin is here. I've put here the RHFC website, which, because we are an open and collaborative coalition, you can find the RFP addendum, you can find the RFP, you can find all sorts of fact sheets, as well as the video that I shared, as well as my contact information is there for anybody who has questions. So we're very pleased to be here and answer any questions that you might have in the remaining time, as I know I'm standing between you and lunch, which is always a dangerous place to be. So thank you.
Thank you, Julia, for a very good presentation. Reminded me of those days, my lecture topics with JSI, getting supplies. You know, I listened attentively, but I've seen the prototype approach you want to put. But in all of it, what I see is how you get supplies to those who need, those in need. But the real topic for today is talking about track and trace for access to safe medicines. And that aspect, and also looking at the presentation by WHO on prevention, detection, and then what do you do? I wanted to see a linkage. Issue of reproductive health is one that has been taken in the front burner together with HIV, AIDS, malaria, and tuberculosis. And one thing that has been of worry are getting falsified and substandard contraceptive commodities to the public. How does this do that? Where is the connections? Is the GSI-1 product going to pick all this? For example, at production levels, we have bad practices. Bad practices, it is not about the level, it's about the product. The level can come, it originated from a genuine source. But with a bad practice, what is there is already substandard. In the process, those people who are in operation, in the warehouse, the drivers, at all other levels, and most times we have noticed they are capable to avoid stockouts. They find other means of filling that gap. How is this? Those days were bugged. If you look at the cycle, what is in the center then is the logistics management information system. We sit down hours to develop CPTs from LMIS with so many inputs, with headaches. Technology has narrowed many things. But then what can we get out now with the GS1 approach to reduce the risk of people getting substandard and falsified medical products?
Great. Thank you very much for the question. And I think making the linkages is one of the most important things for these communities as we talk about these big ideas. So just one of the things, this is an important question. As we heard, one of the first steps with GS1 is to identify. And so our vision in terms of scope is to start with really this idea of having all the data in one place and that it's identified. So we actually start by making sure that we are able to have the product master, that we're able to identify the products, and that everyone's able to see that data. That is sort of scope number one. And we're talking about right now the upstream, getting from procure down to the central medical store. One of the very important points you mentioned there was the linkages with the ELMIS and what the countries are doing in country to then link up central medical store down to the last mile. And so I think this question of the track and trace is top of our mind, but we're also aware of the importance of implementing in the right process and steps. And so we wanted to start with the identification, using the right standards, and go from there into the terms of capturing and sharing and into actually thinking about expiration and the complication that it gets to as you think about serialization, which is where you get closer to the actual product and be able to follow it all the way down. So this question of barcoding and serialization and being able to follow that product is there, but it's not the scope that we're starting with as our first step. We need to start first with identifying the products, getting the standard in place, getting everyone on the same platform, and then we move towards that. So that's the approach that we are taking.
Thank you, Julie. This is a nice update for those of us who were part of these discussions a few years ago. My name is Chris Wright. I'm here representing the Gavi Alliance, where there's among my scope, I'm working with Gavi to determine where they're going with this sort of global visibility opportunity. And there is definitely some need and I think some appetite. So given that, can you talk a little bit about what have been the challenges that you've encountered so far and what sort of challenges do you anticipate coming as you progress down this road?
Sure, I'm happy to. Actually, a lot of the innovations are to tackle the challenges. So the innovations that I mentioned really highlight some of the challenges in terms of themes. So one of the challenges that we tackled and had to come up with in terms of an innovative approach was around defining the requirements and the system selection process that we're in. So I think one thing that's really important when you're looking at the global level is the number of stakeholders and the collaboration. The collaboration has to be at the heart of it. It is not one entity that is going to make this global visibility work. It's the engagement of all those key supply chain players across the supply chain itself. And so when it came to the RHSC coming on board, one of the biggest challenges over the previous years of talking about global bans that we were introduced to was this challenge of how do we all agree on what the requirements are? Do we do it in terms of all public health together? Do we do it in terms of specific health areas? What's going to be the right approach? So that was one of the challenges, and that's why we took this innovative approach to really trying to put in place a very collaborative visual approach to getting those partners involved that I was talking about in terms of using Basecamp, in terms of going through task forces. I think it's another reason that the RHSC was specifically tapped for this, so that it's seen as a community initiative rather than one entity's particular initiative. It's seen that all those entities go through the community together, work on it together. They're working through a neutral entity like RHSC that has the intention of making this work for everyone and giving everyone a voice. So that's one of the challenges that I know as people embark on this, getting that, it might sound easy, that getting that requirements document, but that one document took years to actually get to. So getting that in place was definitely a challenge. And not to take too much time, just your second part there of what's a future challenge, I don't think we can underestimate the challenge of data sharing and policy. So we are up against this right now. We are deep in the heart of it. And I think, again, it's a community initiative. The expectations of everybody to share are there. The value proposition only works if everybody's sharing so that everyone's getting a piece that they didn't have before. And is looking at that data at the same time. Policies can really hinder that, and bilateral data sharing can hinder that, and the fact that data is seen as power can hinder that. So I think we can't underestimate that we all want this, but in order for that to happen, policy change has to happen, and people have to be willing to look at how that policy works and make those agreements in a new way. So maybe I'll give you an update on that in 6 months to a year, because that's the big piece, is if there isn't data, it doesn't work. So thank you. Thank you.
Thank you so much. Thank you very much, Julia, for this insightful and inspiring way at looking at the supply chain. And it's the German in me who is asking that we have the break now. And I'm very happy that we did it. Thanks for all the participants. We will now move into the lunch, but I just want to quickly introduce the afternoon session. So after the lunch, we will split this room in two, which also lets me ask to, first of all, really take all your belongings with you and give the translation devices back. We will redistribute after this room has been split into two. There is one part of the afternoon which is committed to a think tank. People who can be part of that have gotten an invitation from Geraldine. I don't know if Geraldine is here. If she is, can you stand up? Yes, she's in the back. So Geraldine is leading the think tank discussion this afternoon, which is for regulatory bodies, international organizations. And for the other half, we will go into the details and the practical details of traceability, how to get started, how to pick the right data model. When Lee got the question, how is the data source in the US? Well, the US has not yet decided. The US FDA has not announced. The stakeholders are still discussing. So what are the different possibilities which you can pick as a data model, the advantages and disadvantages? That's the afternoon. And after you have had hopefully very interactive sessions this afternoon, we invite you to the so-called poster session, which is a tradition at our conferences. There are posters exposed which are showing some of the work which are going on in the world. And let's meet there for having a chat and a glass. With that, I also wanted to say that all the slides, when we get the permission, will be up on our website tonight. So they will be shared. We have the lunch outside. In the room behind that, there is a seating lunch. Outside in the beautiful weather, there is a standing lunch. So enjoy. And if you have any questions, the ladies and the gentlemen with the green ties have that on so that you easily find somebody who you can ask if you need help. Thank you so much. Enjoy lunch and see you back in the afternoon session and at the poster reception. Thank you. Great presentation, Julia. Really, that's
Something low, scatterings and fugitives.